Welcome to the Pancreatic Cancer Panel at the 7th International Symposium for Focused Ultrasound. My name is Juho Huang from Stanford University, and I will be the moderator for this session. We will be hearing presentations from Holger Grill from the University of Cologne, Jae-Young Lee from Seoul National University in Korea, Srikanth Reddy from Oxford University Hospital, and Joan Vidal-Jovi from Institut Coab from Barcelona, Spain. I'll be speaking on a variety of topics ranging from preclinical work to clinical trials, which highlights the tremendous potential and advances that have been made in pancreatic cancer using focused ultrasound. Following these presentations, we'll have a live panel discussion with the presenters. So if you have any questions, please be sure to enter them in the chat box and we will address them to the panel. And with that, we'll begin with Professor Holger Grill's presentation. Thank you.
First of all, let me thank the Focused Ultrasound Foundation for the invitation. My name is Holger Grill. I'm from the University Hospital of Cologne in Germany. In Cologne, we work with the MR-guided HIFU sonarleaf system, which we intend to use for the treatment of pancreatic cancer. I would like to share with you the results of our preclinical safety study and some aspects of our trial design. MR HIFU ablation of pancreatic cancer is particularly challenging for several reasons. First of all, the pancreas is located behind bowel and stomach tissue at a depth of about 7 to 16 centimeters, depending on each patient. To assess the typical depth and dimension of pancreatic tumors, we did a retrospective analysis of PDAC cases in our hospital. Measured from skin, the majority of all tumors are at a depth of about 5 to 12 centimeters. Thus, a considerable number of patients are within reach of our system. The challenge of MR-guided ablation is to get robust MR thermometry readings, which are compromised by motion. The respiratory motion alone is about 2 centimeters up and down, and in addition, the pancreas is affected by peristaltic motion. To prepare for the clinical trial, we performed a safety study in pigs, which I would like to share with you. To facilitate acoustic access to the pancreas, we first designed a dome-shaped polyacrylamide gel spacer, which is acoustically transparent. It partially displaces and compresses the bowel and stomach tissue in front of the pancreas, creating an acoustic entry path. Currently, we are evaluating a set of different geometries, which we will test on volunteers to define the exact spacer geometry which we'll use in the clinical trial. As an example, I would like to show a treatment where we placed a 4 millimeter treatment cell into pancreas tissue. The sonication was performed under general anesthesia with intubation during a knee phase that lasts up to 90 seconds. The ablation was performed with 300 watts output power, and the temperature in the target reaches about 67 degrees. Based on the measured temperatures, the system automatically displays the thermal dose contour lines of 30 and to 40 CEM. The latter is widely recognized as a measure for thermal necrosis. After sonication, we excised the pancreas tissue and compared the dimensions of the lesion found in gross histology to the non-perfused value obtained with MRI and to the lesion dimension obtained from thermal dose 240 cmm maps. Furthermore, we confirmed that thermal ablation on H&E stains in histological sections. Overall, we performed 10 sonications, out of which 8 were successful. In one ablation, we had a blockage of the beam path by feces that were still present in the bowel, and in another ablation, we observed off-target heating due to movements and could abort the sonication. All ablations were successful and were confirmed on H&E stains, and we did not observe any side effects. Now we evaluated the best measure to control the treatments. First, we looked at the applied output energy and found a rather poor correlation with the lesion size derived from gross findings. This result is quite logical and expected as tissue layers in front of the pancreas differ in absorption thickness. Therefore, the energy that is actually deposited in each experiment within the target tissue differs for the same output power. Next, we used the thermal dose 240 cm as a measure and compared that to the gross finding, yielding a rather linear relationship. Also, the NPV measured with contrast-enhanced MRI post-treatment correlates well with the lesion size obtained from gross finding. As the 240 cm correlated well with the obtained lesion size, we are currently testing the thermal feedback control capabilities of the sonarleaf system to automatically perform pancreas ablation. In this example, we placed an 8 millimeter feedback cell into the pancreas with an output power of 300 watts and then simply used the automatic feedback cell until the 240 cm perimeter matches the target cell. I would consider this the most compelling feature of MR-guided HIFU, as the integrated thermal feedback allows to deliver a well-defined thermal dose to the target. This was a very successful ablation, and the correct lesion size was confirmed with NPV measurements obtained with MRI and CT. For treatment of pancreatic cancer, I'm now very confident that we solved all issues related to technology and clinical workflow, and we are ready to move into the clinical trial, which is scheduled to begin next year. So let me summarize where we stand with our trial design. We aim to include 30 patients with biopsy-confirmed PDAC in a stage 3B and 4, which make up about 80% of all patients. The aim of the study is a proof of concept and feasibility study of pancreatic cancer ablation using the MRI Sonderleaf system. As a primary endpoint, we so far defined tumor destruction by thermal ablation, which we can measure on follow-up MR and ultrasound scans to obtain the non-perfused volume and the tumor volume. As a secondary endpoint, we will measure pain score and quality of life because we expect an improvement of quality of life simply from tumor debulking. Furthermore, we will assess the frequency and severity of any adverse events that may be a consequence of the HIFU ablation. Overall, we will measure the ablation efficiency and the NPV ratio while changing the ablation strategies over time. Furthermore, we will take before and after the treatment blood samples and tissue biopsies to assess any potentially immune response. We are currently in the last phase of drafting our study protocol and hope that we can start the trial early next year. With that, I would like to conclude. Thank you very much.
Hello, I am Jamie. I'm very delighted to talk about our prospective study for safety and initial efficacy of combined treatments of chemotherapy and focused ultrasound for unresectable pancreas cancer. The purpose of our study was to check safety of combined treatment of FUS and anti-cancer drug for patients with unresectable pancreatic cancer using mechanical dominant FUS conditions and to determine the optimal FUS intensity by comparing efficacy. 3 intensity groups were determined based on the results of our clinical studies. A low intensity group 1.5, intermediate intensity group 2.0, and high intensity group 2.5 kilowatt per square centimeters were used, and 1% duty cycle was set to maximize mechanical effect. We used 3+3 escalation dose scheme. Beginning low intensity group, 3 patients were designed to be enrolled in each group. If adverse device effect or dose-limiting toxicity occurs in 1 patient, 3 patients added in that group. If ADE or DLT occurs in more than 1 patient in a group, this study was designed to be discontinued. This slide shows inclusion and exclusion criteria. And the combined treatment of FUS and gemcitabine and paclitaxel was repeated weekly for 2 months, total 6 times per patient. This slide shows the device we used. This photo shows I am treating a patient with pancreatic cancer. There is a large pancreatic cancer invading mesenteric vessel. PET-CT shows hot uptake. Ultrasound shows bulky pancreatic mass with good acoustic window. This slide shows real-time appearance of FUS treatment for this mass. 3 months after this mass was reduced in size with size change ratio of -33%. This is another case. There is a pancreatic head cancer invading SMA and SMV. 3 months after treatment, this mass was reduced in size with extensive necrotic change. The size change ratio was -37%. In result, each 3 patients were enrolled in each intensive treatment group. There was no difference in age, sex, initial stage, initial size, physical performance scale, and CA99. No adverse effects or dose-limiting toxicity occurred in any patients. Therefore, increasing number of patient enrollment was not needed. This graph shows size change ratio of pancreatic cancer 3 months after treatment. Intermediate group, intensive group showed all decreased in all patients with median of minus 40%. In terms of change in CA99, intermediate intensive group shows a remarkable change in CA99. Regarding survival, all patients in low intensity group and high intensity group died, whereas all patients in intermediate intensity group still survived. This table shows survival from the treatment and survival from the diagnosis. Intermediate intensity group shows statistically significant longer survivor from the treatment and from the diagnosis. A Kaplan-Meier survival analysis from diagnosis of pancreatic cancer shows that intermediate intensity group is the best with significant p-value. And Kaplan-Meier survival analysis from combined treatment also shows that intermediate intensity group shows the best survival with a very low p-value. The limitation of our study is small number of patients enrolled and low control group. In conclusion, the 1.5 and 2.5 kilowatt per square centimeters first intensity with very low duty cycle were safe in the combined treatments of first and NPAC and gemcitabine. Intermediate intensity group showed the best results in tumor size change, tumor response, and survival. So we will design a prospective randomized controlled trial. Thank you for your attention.
I'm going to share our experience of using focused ultrasound therapy for treatment of pancreatic cancers. We set up a clinical pilot study in Oxford in the United Kingdom. As many of you will know, pancreatic cancer has a poor prognosis, and less than 10% of the patients are alive at 5 years following diagnosis. Surgery with chemotherapy gives the best chance of a cure or long-term survival, but less than a fifth of patients are suitable for surgery at presentation. Hence, new treatment strategies are urgently required. Immunotherapy has made a big difference for a number of patients with other cancer types such as melanoma, but has been ineffective in pancreatic cancers. Pancreatic cancer is described as being immunologically silent. Techniques to stimulate pancreatic cancer antigen release and processing are required. We are working on hypothesis that high-intensity focused ultrasound therapy will increase the tumor-specific antigen release and generate systemic immunity in patients with pancreatic cancers. This is a schematic diagram showing how T cells in our body recognize cancer cells, and cancer cells would have put a brake on the immune system using this PD-1, PD-L1 pathway. An immune checkpoint blockade acts by blocking the PD-L1 and anti-PD-L1. And what we're hoping is to harness the immune system of the patients by using a combination of focused ultrasound therapy and immunotherapy in the future. The trial design involves recruiting 20 patients who have got locally advanced unresectable pancreatic cancers. The primary endpoint is a safety endpoint of mortality and morbidity at 30 days following focused ultrasound therapy enabled ablation. The secondary endpoint is how successful focused ultrasound therapy was in ablating the tumor and whether focused ultrasound therapy causes immune activation in patients with pancreatic cancers. This is a schematic diagram of the trial design. Patients with pancreatic cancer will undergo an MRI scan of the abdomen and ultrasound treatment planning to make sure that the pancreatic cancers can be treated using focused ultrasound therapy. And after recruitment into the study at this stage, baseline immune profiling will be undertaken, and then participants will undergo ultrasound-guided ablation of the pancreatic cancers. Following ablation, immune profiling will again be done in 2 weeks' time using T-cell receptor sequencing and flow cytometry. 4 weeks after ablation, patients will undergo an MRI scan of the abdomen to see how successful focused ultrasound therapy was in ablating the pancreatic cancers. We have screened more than 100 patients in our multidisciplinary team meeting. 18 patients were found to be suitable for the study. However, 16 of them had to be excluded for a number of reasons, such as the cancer involving adjacent organs such as stomach and duodenum or major blood vessels. And some participants were also sent off for chemotherapy or radiotherapy. 2 of the patients were approached and both of them agreed to take part in the study. And once the study was up and running, unfortunately, COVID has stopped recruitment. But we have now restarted the study and we have got 4 participants who are suitable for ablation, who will undergo this therapy in the next few months. What have we learned in setting up the study? The tumor location and proximity to adjacent structures limits the application of ablative therapy to majority of the patients with pancreatic cancers. There are also competing therapies such as multimodality chemotherapy and radiotherapy who compete for the same patients with pancreatic cancer who want to take part in research. However, reassuringly, all the participants we approached for focused ultrasound therapy were enthusiastic about the study and agreed to take part in the study. In terms of our future work and vision, we want to combine focused ultrasound therapy with chemotherapy and increase the number of patients who undergo curative surgery with negative resection margins, and also convert patients with locally advanced pancreatic cancers, which is a third of the patient population, from unresectable disease to patients who could have curative surgery. We also want to combine focused ultrasound therapy with immunotherapy in patients with metastatic disease, which is half the patients with pancreatic cancer at presentation. Thank you.
Okay, thank you to everyone to allow me to present this clinical data of pancreatic cancer treated with focused ultrasound. For ones that know me, we have several years experience of treating pancreatic cancer with focused ultrasound. And on these years, we have learned a lot of things that should be done, a lot of things that should not be done. And because of our experiences, some extended, so we can help you to avoid difficult situations that you can find when you treat those cases. So pancreatic cancer is probably the most challenging gastrointestinal malignancy to be treated with focused ultrasound because it's diagnosed in later stages, because it's surrounded by other structures. So the anatomy is very difficult surgical and ablation access, the stroma is strong and treatment penetration sometimes is very challenged, and because has a low immunity possibility that is probably not going to be very well treated with normal immune or chemotherapy treatments that are available at this time. So some of our colleagues have published that at this point, the ablation with focused ultrasound is probably the most effective that we have compared with the others, because it's non-invasive, because it's repeatable, because guided with ultrasound, we see what we're doing. So it's very, very well located and very well seen what's had been done, because there is no need for needles, electrodes, or probe. And there are no ionizing radiation. The ablation that we obtain is very precise, and the results are very well obtained when we treat with this modality. So in our case, it's been around 11 years that we've been treating those cases, and we have treated almost 80 cases of pancreatic tumors, non-resectable stage 3 and 4. And in our case, compared with historical controls in our institution, we have an overall % survival that is better than these historical controls when we treat patients with a standard treatment, which is chemotherapy and focused ultrasound. So what we find when we're going to treat those cases is that we may find a small bowel or colon interference between the tumor and the sonication device. There is also the risk of tumor invasion of the duodenum. There is placement of the biliary stent that should be done, and sometimes it can overshadow the tumor and make difficult the ablation. Then the bowel, the biliary, or the pancreatic duct may become obstructed after the treatment, and that may risk some complications. And also the vessels that are surround the tumor may be invaded, and that may become another added difficulty. So the actions that we recommend to be taken when we're treating those cases, in the case of the bowel interference, positioning probably is the best action we may take. Moving the patient around, moving the patient is what's going to avoid us to have the bowel in the middle of the sonication treatment. Or if not, we can use what is called a water balloon, that it's put it between the belly and the sonication device and spreads and displaces and puts aside the bowel on the sides of the belly, and then it's not in the middle of the focus of treatment. In case when the duodenum is affected, we do not recommend treated, because there is a risk of perforation in that moment, or a risk of delayed fistula formation. Also, we recommend that when we are going to treat a pancreatic head tumor, that we always put a stent placement. This is because that's going to avoid the problems related to biliary duct or pancreatic duct obstruction, but that may add a problem, which is that the shadow that the biliary stent makes on the back of the tumor. And we solve these using different angles of sonication to cover back space of the tumor. In case of the vessels that are surrounding the tumor, we do not recommend treatment if there is a thrombus inside those vessels, because that may, at the end, make the risk of metastasis higher. So we are going to show you some images of those cases that we have explained. This is a case that's been treated. So here what we see is the tumor, that is the tumor of the pancreatic tumor, which a very nice response when it's being treated between the belly and the abdominal wall and the stomach. So this is treated through the stomach. The stomach has a very thick wall that is not affected by the sonication, and we see here the ablation on the pancreatic head. This is another case, probably is the best case scenario. We have the stomach in one side, the liver in the other side, and in the middle there is the tumor with a nice path of the sonication that we will obtain here, a very nice ablation of this pancreatic tumor. This is a case that we have not treated. So this is a tumor with inside there is the stent, but this tumor invades the wall of the duodenum. So here, if we treat this, there is a huge risk of either perforation or delayed fistula formation. This is another case with a tumor on the pancreatic head, that this is has a very nice position because it's just behind the segments 2 or 3 of the liver, and allows us to do a nice sonication because the liver is not affected, and we will be able to obtain here a very nice ablation. Another case just behind the stomach, liver and stomach, and this is a tumor of the pancreatic body, which we can also obtain a very nice ablation. Another case with a vessel inside the tumor, this ablation can be done, but there is a risk here because it's close to the duodenum. We see duodenal stent, and there is a risk here that we can make a perforation. But if we treat only this side, that will be a nice ablation. So this is one of these cases that we see are on the middle. This is another case with a superior mesenteric vessel here that is inside the tumor. In this tumor, we can treat it very well because the vessel is patent, there is no thrombus, so we can treat it with no problems. The same here with the hepatic artery and the celiac trunk, and we see here how we can treat the tumor on the body of the pancreas with no affection of those vessels and with this nice ablation seen. Another case of the pancreatic body just behind the liver and the stomach, and this will be a very nice ablation to be done. And also the same here with this cyst and the ablation tumor that will make a nice ablation path. So thank you. I hope this has been very useful, and I'll be ready for questions when you decide.
Hi there, I'm Juho Huang, and I hope you enjoyed the presentations from the panelists. And so right now we'll go on to the Q&A section of this, and we'll start with a question to Holger. So you've done, it's you and your lab has done extensive work, preclinical work, especially looking at targeted drug delivery. There are many barriers to getting this to clinical work, and that's ultimately what we're trying to achieve. What do you think are the main barriers in both from kind of three different phases? One would be what are the scientific barriers, and then what are the regulatory barriers, and probably even more importantly, what are the commercial barriers towards getting this technology to patients?
Yeah, so thanks for the question. That is three very important parts. So let me address it one by one. I think technically there is really a plethora of preclinical studies out that demonstrated temperature-induced drug delivery with temperature-sensitive liposomes. And I think if you look in literature on small animals and home-brewn liposomes, there is a lot of formulations out there, from dogs being one of the most prominent ones, but we also in our lab work with cisplatinum, gemcitabine, and a couple other formulations, and others worldwide do the same. And now if you look at the clinical availability, I think there's only Thermodox out there, and there's one other lead compound, Thermosome, from a German company that is reaching clinical stage, but these are both doxorubicin-based formulations. Now, if you look at the sensitivity of different cancers towards doxorubicin, I think pancreatic cancer is not that sensitive to doxorubicin. So I'm a little bit afraid that conceptually it may work to do temperature-induced drug delivery in the pancreas, but I have yet not really a feeling how sensitive pancreatic cancer might be to a high dose of dox delivered with this technology. So that is basically on the drug level. So what we would need is also temperature-sensitive liposomes, maybe of cisplatin, gemcitabine, or other compounds that are more where PDACs are more sensitive to. And then on the technical level, we worked with MR-guided HIFU for hypothermia, where temperature feedback is key. That works in stationary targets really well. We are down to, let's say, less than a few tenths of a degrees, basically in constant temperature of half an hour. But when it comes to moving target, we're currently working on it. And there in the pancreas, I think we are confident to get maybe to half a degree to 1 degree at this point in time, and maybe with future technology even better. And then I think we have to look at how long do we need to maintain the temperature to do that. Something like 10 minutes enough, or do we need to go for half an hour or even longer? And as longer you go, as more challenging it gets, right? And then I think for the last part, it's of course commercialization. I think if we really want to bring it into the clinic, we have to have a clinical partner. that develops those formulations. And as I just said, I think at this point in time, there are only two thermal doxorubicin-based formulations out there. So, and I see this as the main hurdle. I think it's not so much in the patents, it's really, I think, the commercialization to get it into the clinic.
So are there any downsides to administration of temperature-sensitive liposomes in terms of clearance and how long the drug actually lasts? And a follow-up question to that is, why not just use cavitation? You know, you mentioned how difficult it is to keep an area heated for a prolonged period of time. Why don't we just use mechanical cavitation in drug-loaded bubbles and deliver drug that way?
So first of all, the temperature-sensitive liposomes provide us with a, let's say, reasonably long circulation time. So the plasma level of doxorubicin and the area under the curve that you need is fairly high. That translates for doxorubicin typically in values of factor 10 to 25 more doxorubicin in the target area, because over the entire heating period of 10, 15, 20 minutes, you deliver doxorubicin to a very high amount. Clearance, I think, is not so much of a problem because there are non-temperature sensitive liposomal formulations that are approved. So I think from that perspective, side effects and so forth, it's not so much of an issue. So I don't see any downsides of that approach. And to your second question about microbubbles, so I think from opening of blood-brain barrier and all the other applications of microbubbles, we have learned that the circulation times of microbubbles is fairly short, so just range of maybe a few minutes. But the effect is lasting much longer. So the permeability that we induce has a much longer time span than the circulation time of the bubbles. And so I think a co-administration of a drug and a bubble is more favorable than drug-loaded bubbles by itself. Because once we use cavitations, let it be stable cavitation or inertial cavitation to induce permeability, then the drug that may have a completely different circulation time can get into the tumor because we have an enhanced permeability effect. And it's not, the pharmacokinetic of the drug is not bound to the pharmacokinetic of the bubble.
Okay, very good. Let's move on. Let's move on to Jae-Young Lee, and very nice talk on your clinical experience with drug delivery. One question from the audience is that you showed remarkable results with the intermediate, but not so much with the high intensity group. So what do you speculate the difference was there?
Okay, so we thought it is also interesting because intermediate intensity group showed the best result above high intensity group. If you see my slide, you can realize that high intensity group had different treatment before HIFU treatment, whereas intermediate intensity group had first treatment as HIFU as a first treatment. So I think it might suggest the difference between intermediate intensity group and high intensity group. Anyway, I came to conclusion that intermediate intensity group had the best result. So above intermediate intensity, it surely give an effect to patients.
Okay, and so one of the other practical considerations with your protocol is that you are administering drug and doing HIFU relatively closely together. What are the logistical challenges? I mean, are you actually administering the chemotherapy in the radiology department? I know at our institution that would be very, very challenging.
Yeah. So there was no issue at all. So chemotherapy was done in oncology department, and treatment was done in radiology. So it is possible based on close cooperation with oncology department and our department and full understanding of our research. So we have good team, so no problem, no issue, no challenge.
So it just requires a lot of coordination because you have to get the timing correctly, right?
Right.
Fantastic. Well, let's move on to Shrikant. I know that you've just recently started doing HIFU treatments of the pancreas at Oxford Hospital, but you have a long history of doing ultrasound-guided HIFU at your institution. What's been the challenges of setting up a pancreas program at your center? Because obviously you have to get buy-in from your oncologists and your surgeons.
I think there has been a lot of enthusiasm from the team, in the sense it helps that as a surgeon, I chair the cancer MDT. So in a way, I can choose the patients for the trials that I feel that I should support them. That helps. But I think the main barrier, Juha, has been actually we have had to screen a lot of patients, and we have a very experienced ultrasound operator. Fang is the one who actually does the treatment, and he's got a lot of wealth of experience. And despite that, my experience has been that actually we're only able to treat 10 to 20% of the patients that actually we put forward for treatment. So most of the patients, I think, because of I think ablation perhaps is going to be challenging in the pancreas because of its proximity to the bile duct, to the duodenum, and actually the main limitation has been the technical ability to ablate it satisfactorily. On the upside, there has been patients. Almost all the patients we approached have been enthusiastic about it, and they're keen to take part. I think the challenges have been technical rather than acceptability by the other members of the team. And you also rightly point out that there are competing modalities. I think one of them has been neoadjuvant chemotherapy. So we're converting increasing number of patients who are borderline resectable or not resectable. Even a couple of years ago, a proportion of them get converted into resectability. And the second is, of course, ongoing radiotherapy studies. They can't get it work, but of course they're modifying their protocols using stereotactic ablative radiotherapy. So I think there are competing modalities for the same patients, but the challenge for now till now has been mainly actually finding the right patient to apply the technology.
So who is the right patient? I mean, where do you see that HIFU has benefit over other technologies?
I think if you ask my frank opinion, I think the future perhaps is actually combining it with drug delivery. I think if we're relying entirely on bland ablation, I think it's going to be a big ask to make a big impact on any significant number of patients. So I think currently the patients that I find that are suitable are actually more in the neck of the pancreas, because the ones in the body and tail, they can usually be resectable because they're away from the major vessels. And the one that is right in the head of the incident process, it is close to the duodenum and the bile duct. So the ones that are sitting in the neck, involving the celiac axis, the superior mesenteric vessels, those are the ones that seem to be suitable. And of course, we are choosing only patients who have got locally advanced disease. But because our study, I think one of the important parameters we're going to study is to see whether we can pick up immunological signals. We also are perhaps asking for ethics applications to include patients with low volume metastatic disease to expand the available patient pool for the study.
Yeah, I'd have to agree with you. I think that the thought to get complete ablation with HIFU really is unrealistic. I think there's too many critical structures, and so really, I think the sweet spot for focused ultrasound for the pancreas is whether, one, drug delivery, and then two, whether or not we can somehow elicit immune response, either from thermal mechanisms or from mechanical mechanisms that then somehow elicit a systemic response in conjunction with potentially some of the immune modulators. I think that really will be the future. And, then the benefit of focused ultrasound is it's completely non-invasive. As opposed to all the other alternatives, which have some component of invasiveness. So I guess stay tuned, right? I mean, the way I saw it, because I was going to, do a study many years ago using an ultrasound-guided system. We need to do ablation to essentially demonstrate that we can target the pancreas. But I think the future modalities for treatment will be really based on drug delivery or immune response. So let's move on to Gail, our our physicist of the group. And the questions that I wanted to raise with you, we have more and more people who are coming into the fold who might not be really that well versed in terms of the complexities of focused ultrasound. I mean, I think that people think of it in very simplistic ways of, okay, we got a transducer and we're just focusing energy in, but we all know it's not that easy, right? And so, what is your advice in terms of clinicians who find this technology to be interesting? How do they get involved? How do they learn the basics of focused ultrasound?
Well, those are really good questions. I mean, I'm a physicist working in a hospital. I would say that go and find your hospital physics department. Go and find the people who do ultrasound imaging, because although you may be doing ultrasound guided or MR guided, you still need to understand the principles of the way in which ultrasound interacts with tissue in the body. So you need to know what you can and can't target. You need to know a bit about image formation, therefore. You need to know what happened, which structures in the body heat, which structures in the body reflect, where you're more likely to get cavitation, depending on what sort of treatment you're going for, whether it's a bubble-based treatment or a heating-based treatment. There are basic textbooks out there, but I think basically a clinician should go and seek out a hospital physicist or a local physics department if you haven't got hospital physics in your country. I don't think, I mean, we've heard from Srikanth, we've heard from Holger, it's a difficult treatment to do. You need to understand the basic science, you need to understand a bit of the engineering, you certainly need to understand the physics, and the physicists need to understand the biology, of course, but it's a collaborative thing, and without a collaborative team, you're not going to go anywhere.
Do you think that there's a minimum criteria for understanding some of the physics of ultrasound that a physician should really understand before even pursuing patient therapy? Like, do we have to set up a course and credentialing for this?
I think we should be setting up a course. I think what we're missing is a really basic text. I mean, actually, it doesn't have to be very long. I think if you understand the way in which ultrasound creates images, you've gone a long way along that path. Because as I say, you need to know what reflects the sound, what absorbs the sound, which structures you're going to get most heat in, where you're going to get most cavitation. And that's a good start. But yes, I mean, very, very basic understanding.
So basically, I mean, it sounds like radiologists would pretty much have a good basic understanding, since that's required in their curriculum in order to understand ultrasound imaging. So also,
yeah, it gives them a basis to work from, or get basis to build on.
Well,
and of course, if you're going to do MR guidance, you need to understand a bit about MR imaging as well. But
well, that's a good segue kind of into talking with Juan, because you are a clinician. You had essentially no experience in focused ultrasound, and how did you get involved, and how did you learn about focused ultrasound for treatment of the pancreas?
Well, basically, I went to China, and I had the opportunity to see how they were doing the treatments, how they were doing the approach to treat that way. And then when I got back to my country, and I had support from one group of Chinese colleagues that were used to come and every time that I had a case. And then after a few cases, I was on my own. And then the experience of a surgeon doing an ablative procedure in a pancreas is very valuable, because you've been inside and you know what you have there, and you know the difficulties, how deep is the tumor, how close it's to a vessel, etc., etc. And I agree with you when you were saying that 100% ablation of pancreas, it's unrealistic, because it is. I think we can. I would like to say an optimal ablation, and that's it. And probably this is 80% or something like that. But probably this type of ablation can be done and can be used to enhance an immunological response, drug delivery, etc., etc., etc.
We only have a couple minutes left, so I want to ask one important question, as a clinician who has probably the most experience, what's the biggest complication that you've experienced with the focused ultrasound treatment of the pancreas?
I had two, I would say two. One is a bleeding from the gastroduodenal artery because we had some pancreatitis in the head of the pancreas, and this pancreatitis provoked a bleeding, and then that was solved very well with the help of a gastroenterologist, cutting this bleeding. And the other one was a fistula formation, a delayed perforation, because we had a fistula between the tumor and the duodenum. And that was a delayed perforation that had put the patient in the ICU, and we had a very, very hard time with this.
All right. Yeah, so I think that, we'll come to the conclusion of this panel discussion, but I think that the summary I have is it's very promising. We're still at the beginning. We're treating, which is great, but I think we still need to gather more data and a better understanding. So thank you very much. And I appreciate, thank everyone on the panel, and thank the Focused Ultrasound for hosting this. So on to the next session. Thank you.